DNB graduate, and she has also done the certificate course on child and adolescent mental health from Dr. Porpave, who is a child and adolescent psychiatrist from Australia. And it's also a pleasure to say that me and Jayashree both run this teen wellness clinic for the past 1.5 years. So we do this together. And also we are also associated with doing many school programs related to adolescent health. And she's always interested in doing these programs, and she always and offers to come and do these programs. And Dr. Nivedita is a young psychiatrist. She was graduated MBBS from PhD Medical College and MD Psychiatry from JIPMER, Pondicherry. And she has vast experience in dealing with child and adolescent mental health. And she's worked in both the prestigious premier institutes of our country, which is AIMS and JIPMER. Under areas of interest are child and adolescent psychiatry, addiction psychiatry, behavioral addiction, psychotherapy, neuropsychiatry. So with this brief intro about both the speakers, we'll move on to the session proper. Dr. Jayashree, over to you.
Thank you so much. I hope I'm audible and I'm visible. The slides are visible.
Yes, Jayashree.
Okay. Good evening and respected seniors, my dear friends, the members of Central AHA and State AHA and Tamil Nadu IAP chapter and Central IAP chapter, who have all taken time to join our session and kickstart the first academic program of Tamil Nadu AHA. My sincere thanks to all of you. This topic, as Dr. Lakshmi said, was suggested by the Central AHA, Dr. Shami Ghosh. And I think this also helped me to learn more in depth about this condition, which we commonly see nowadays, more so after COVID. So we come across adolescents with functional disorders on a day in and day out basis. It is often a dilemma for pediatricians. As clinicians, we are always trained to look at the proper history. Then we do physical examination. And finally, we also do some investigations as and when necessary. Many a times, none of this give any clue to what the adolescent is going through. And that is when we think of functional disorders. So this is indeed a dilemma. So the scope of my talk would be to give a better understanding of what has changed about functional disorders in the recent past. As pediatricians, how should we approach this? We will have 2-3 case scenarios and also find out what is the pathophysiology and when to seek the help of the other specialists, especially a psychiatrist. Now, when we come to define functional disorders, we all know that this is characterized by persistent somatic symptoms. They come to us in the form of having a headache or having an abdominal pain, or it can be a generalized aches and pains. Sometimes it is vomiting. So there is a persistent somatic symptom or multiple symptoms, and they are associated with significant impairment and disability. So we have to understand that this is not a fake. What symptoms they are going through is true, and we need an empathetic approach to understand why they are going through it. So that is the first point. So as our understanding long back was, if we don't find anything organic, it is functional. It is no more so. So it is not a diagnosis of exclusion. This is the second important change we have to remember. So not all the times we do some investigation and then finally conclude that there is nothing organic found, so it is a functional disorder. It is not so. And sometimes these symptoms have typical clinical patterns, but lack a clear organic or psychiatric cause. Then in that condition also, we suspect a functional disorder, but it can coexist with an underlying chronic ailment also. Meaning a child with a chronic functional gastrointestinal disorder can also have a functional overlap. So these 2 points we have to remember when we approach a functional disorder. What is the recent understanding? So we know that when a child is exposed to a distress or a chronic stress, there is a physiological response which is done by the HPA axis. So we have the secretion of cortisol. So this HPA axis, when this distress is prolonged, goes into a pathophysiological mode, meaning either it is underactivated or hyperactivated. So when it is under or hyperactivated, there is less or more cortisol, which is inappropriate to the present scenario, and that is when these children come with various kind of physical symptoms. And this is more to happen in genetically susceptible individuals. So not all the children react to a particular situation in the same way. That is why three things are important when we understand the functional disorder. One is the genetic predisposition can be there. Second thing is there is a pathophysiological response to the stress in this scenario. And third, we have to consider the environmental factors as well. And we often find in functional disorders, we have clustering of symptoms. We do know many a times before exams or an academic pressure or the parental disputes or situations through like put forth by friends in the form of bullying, body image issues and all that, they come with palpitations, breathlessness, hyperventilation or a precordial discomfort, which goes around the heart. So one clustering of symptoms is around the heart. The second cluster you see is around the neurological system, where they come with concentration difficulties, inability to focus, headache, memory impairment, and so on. The third common cluster is around the gastrointestinal system, which is either as nausea, vomiting, functional dyspepsia, or it can be an abdominal pain or defecation disorders. And lastly, it also seems to evolve around muscular and bone and joints. So they come with vague pains and aches for which we are not able to find a clue. Then there is one broad umbrella term called functional neurological disorder. So this is called FNSD, functional neurological symptom disorder. This is categorized under DSM-5. So in this neurological disorder, commonly we see tics. Many of us see children, adolescents coming with tics to our clinics, for which again, we are not able to fix a diagnosis, then we think of a functional tics. So this can involve motor symptoms affecting the limbs, which can be either hypoactive motor system in the form of weakness or hyperactive motor system in the form of tremors, tics, and functional seizures. Sometimes they come with repeated episodes of syncope-like events, but not a true syncope. Then the motor symptoms can also be seen in the vocal cord alone. They come with either aphonia or they come with change of voice, grunt, and so on. Or the motor symptoms can involve only the gastrointestinal tract, like they commonly say that there is a difficulty in swallowing, or they have a global sensation. Or this can involve only the cognitive function, where there is a mental clouding and their inability to focus in academics. So these come under the umbrella term functional neurological disorder. We will see about this. Look at this video. So this child is 8-year-old boy. He was brought by his grandparents. He lives with his grandparents and his mother is working in a government job. So she gets transferred. So far, she had been taking him with her, but this time she left him with the grandparents in spite of his insistence that he would like to come with her wherever she goes. So she lives in Chennai and this child is in Rajapalayam. And this child started doing this conversion movements almost on a daily basis, sometimes once in 2 days or 3 days. It typically happens in the morning when he wakes up and the school bus comes. Because he wants to be with his mother, there is separation anxiety, and he doesn't like the school, so he wants to be in a school in Chennai. So both these factors seem to precipitate this reaction. So what is this symptom? When it comes to experience of symptoms of a functional disorder, it can be involuntary or voluntary. In involuntary, we have the physical symptom, which is now called as somatic symptom disorder. So we don't use the term somatization or a psychosomatic illness or somatoform disorder. These were the previous terms. Now everything has been removed and they say it is somatic symptom disorder, which looks more decent and doesn't have any taboo or bias attached to it. Second is neurological. So the video, what we saw is a conversion disorder where the child brings out this kind of grunting voice and movements and sometimes associated with little hyperventilation. Some children are preoccupied with their symptoms, which is classified as an illness anxiety disorder. So they are not able to come out of that anxiety about their own illness. So these are involuntary, these are true symptoms what they are going through. Voluntary, of course, we have factitious and malingering disorders. What is the difference between the two? In factitious, there is no secondary gain involved. They just want to have a sick role. They feel happy with it. They want attention by the parents and grandparents. They try to dwell in that attention. That is factitious. But if there is a secondary gain involved, for example, a child with dyslexia, in the morning, as soon as they see the bus, they don't want to get in. They fake a headache or abdominal pain. And once the bus goes away, they become fine. So here there is a secondary gain. They want to avoid school. So such situations is called malingering. What is the pathophysiology behind this functional disorder? So we have three important things happening here. As we first saw, it is the HPA axis, which plays the major role in a child getting a functional disorder. So when there is an inappropriate activation of HPA axis with excess cortisol or low cortisol, hyper or hypo, both can bring out a cardiopulmonary arousal or a gastrointestinal arousal or a musculoskeletal tensions. And there is an autonomic arousal which is happening because of chronic body distress. So we know both the parasympathetic and the sympathetic nervous system will be altered and in their function when there is a prolonged bodily distress or an acute severe mental or physical distress. So in both these conditions, you have these two nervous system from the peripheries to the center. This communication is faulty. So this also has a faulty communication to the central sensitization. So the central nervous system also is hypersensitive to all the signals which are coming from the periphery. So put together, we have the end result as a functional disorder. So in this functional disorder, what do we have as changes in psychiatric setting? In DSM-5, it is called somatic symptom disorder. And in ICD-11, it is labeled as bodily distress disorders. In our setting, as a pediatrician, we come across the major symptoms which the child comes with, which is either evolving around the head like tension headaches, or it can be something like a non-cardiac event like syncope, a functional syncope, or around the gastrointestinal symptom as functional gastrointestinal disorders. Now, to understand a functional disorder, we need a biopsychosocial framework. This is very, very important because like any infection or inflammation or common conditions in pediatrics, where we mostly get away by getting a quick history and a physical examination, we come to a conclusion, we do investigate. But here, in a functional disorder, it is not truly evident. However, we try our best to get a quick history or physical examination, we may not have a clue. So that is why here biopsychosocial framework becomes necessary. So we have certain predisposing factors, which are the vulnerable factors. So there can be a functional disorder in the family, or the person, the child himself or herself can be anxious. He may be a perfectionist. So perfectionist personality traits are more prone for this, and a long-standing stress in the form of a family dispute or bullying or academic pressure and so on. So they are extremely vulnerable, which are the predisposing factors. The triggers are the precipitating factors. So first P is predisposing. Second P is the precipitating factors, which can be a illness itself or an emotional trauma like abuse or a dispute of a parent or death of a parent. Or it can be some medical condition which has been wrongly diagnosed or misinterpreted reports, which has caused anxiety in the child. So this starts the symptom. Once the symptom onset happens, then it is perpetuated by the family beliefs and behaviors, how they support this child, or they start doing doctor shopping by moving from one doctor to other with unnecessary medical investigations, which causes more confusion in the child, and the child ends up with more bodily distress. So getting the biosocial psychological history becomes very, very important to understand the child on the whole rather than a superficial approach. So the end result of the maladaptive family beliefs and behaviors will be that the child gets increased bodily distress and somatic symptoms. So we have to get into the depth of the family child dynamics. This is also very important to understand functional disorders. The risk factors are many. It is mostly clubbed into these four. So there are medical risk factors also. So as I said already, functional disorder can coexist with the underlying medical condition, like a chronic pain, a medical condition like the child has gone through a cancer and the child has recovered, or medication side effects. They can also contribute to the development of somatic symptoms later in life. And family, a poor family relationship, conflicts, dispute, and a parenting involvement which is not coherent with the child's needs. Then the social factors like isolation of the child, being bullied, or academic pressures thrust on the child without knowing what the child's capacity is. And lastly, psychological factors like anxiety, depression, and stress are very important factors about which I think Dr. Nivedita will elaborate in a better way. Now, let's move to case scenarios through which we will try to approach now and apply whatever we have been seeing about functional disorders. So this 12-year-old boy, Kavin, was brought by his mother with history of headache of 6 months duration. Headache is gradual onset, dull aching, bilateral frontal. It lasts for about 30 minutes to 1 hour. It occurs on a weekly or bi-weekly basis. But the timing of the headache is more in the evening. So not in the morning that he wants to avoid any school or anything, at home mostly and prior to sleep. But sleep seems to take away the headache. No history of vomiting, dizziness, nausea, visual or auditory changes to suspect a migraine or to suspect any red flag symptoms. In the past 4 months, this headache is occurring more frequently, and he shows also some behavioral change in the form of anger towards his parents, and he has become short-tempered. He is able to sit with his mother for his homework, but he is not able to complete. He becomes very irritable in between. So he is not focusing like before. Apart from this, he is wearing glasses already, and with the glasses, he feels comfortable to read. But he visits clinics frequently with headache. No significant past history, and the family history, there is no history of migraine or any neurological illness. Birth history and developmental history are normal. As pediatricians, we always do a HEDS assessment for every adolescent. So here I would just tell what the significant finding is, history is. In activities, he actively engages gardening. He is very empathetic towards animals. He spends more time with his farm animals. He lives in a farmhouse in a village close to Salem. And he gives water to the cattle, goats. He helps his grandparents to take care of them. And the rest of the things are all insignificant. He is not on any drugs so far, except paracetamol occasionally when the headache is severe. On examination, again, vitals were normal. Anthropometry was appropriate for age. Systemic examination with the glasses, his vision is normal. And ENT evaluation did not reveal any sinusitis, otitis, and dental evidence, no evidence of caries. Rest of the examinations were normal. CNS examination in particular was within normal limits. No red flag signs to point to the brain. So when we approach a child with headache as a pediatrician, we always want an algorithmic approach. So the history here, we did not have much clue, except that it is happening more at home. So there is probably some stress at home. And apart from that, no red flag signs. So we did not do any MRI or CSF study here. So we thought it could be a primary headache disorder, probably a tension type headache, because the symptoms were not fitting into the criteria for migraine, and there were no secondary symptoms to suggest more evaluation. So with this, we can actually conclude, say, tension type headache. We can give paracetamol and send them away, or tell them come for follow-up. So with this, I was still missing something. So I tried to meet them the third time, fourth time they came with the same kind of headache, which was not fitting into anything. So my diagnosis was it is tension type headache. But why is this tension? And then the fourth visit when they came, I called the mother separately because the boy was very anxious. He didn't allow the mother to come to me alone. So this time I asked them to come with the father also. So the father can stay with the boy outside, and the mother came inside, and I sat and talked to her. Then the history was revisited. Now we found out he was abused physically by a male elderly neighbor 4 months back in the cow shed where he used to give water to his cattle and all. That man also used to come there. And the boy revealed this incident to his mother recently. He is very guilty and angry about this episode. But initially, when that happened, he did not have a clue how to approach it, not to tell anyone. And he did not have the courage to also escape and come out. So he had told his mother not to tell this to any doctor. So that was the reason why there was so much delay. And this was a learning curve for me also, because when we think of abuse, in our minds, it is always a girl child. So we never keep this history of abuse when we approach a teenage boy. So uh, that was revealed. And since then, this headache has started. And that explains why he has more headache only at home in the evenings. And once he goes to school, he never comes back from school. He is very happy. Talking to him also revealed that he is very happy with his friends and at school. And sleep, he is totally fine because he tries to escape from this headache by sleeping. And then further probing over phone, the mother revealed that she was abused twice by her relatives when she was a teenager. And she had depression and suicidal ideation about 3 years back, for which she received treatment and she stopped therapy recently. Often, even now, she gets negative feelings about herself. So here we have a family history of a psychological disorder and an abuse, and this child has gone through the same. So probably this is a functional headache, which is a somatic symptom disorder, but we have to keep PTSD in mind considering the maternal history. So he definitely needs follow-up, and he is receiving counseling now. He is advised only analgesics like paracetamol when the headache is unmanageable. Family counsel is also happening with a psychologist, and parents have filed a case against the abuser. So the take-home message will be, unless we go into the depth of the history and probe again, a teenager or the parents will be very, very apprehensive to come out with a history like abuse. Now, moving to the second case scenario, 15-year-old girl Shruti was brought by her parents with history of abdominal pain and vomiting, frequently visiting hospitals nearby for the past 1 year. She is in 10th grade now. Presenting illness, it is acute onset pain, and the pain is significant, very severe, which impairs the child when it happens. And the pain is non-radiating, periumbilical, sharp pain. It lasts for hours and gets better only after receiving treatment in the form of injection. It doesn't get better if she receives any oral tablets. Frequency once in 1 or 2 months, no associated fever or altered bowel habits, no associated extra abdominal symptoms. And her food habits are normal, her menstrual cycles are regular, and this pain does not coincide with dysmenorrhea. According to her, she feels it's more after eating out prior to exams, or when she's forced to eat something by her parents, and lack of sleep, especially during exam times. So these are her personal perceptions about the pain. Coming to the history of heads, again here, the key point was she is a topper in academics, and her teachers have very high expectations of her to get a state rank for the school. And the class teacher regularly reminds her that she should get a state rank and make them proud. And even if 1 or 2 marks are missed, she is reminded of the same, that she should do better. She is little anxious of late, and during exams, and also when the results are announced. She is the captain of the school cricket team. She plays in the inter-school competitions. She has won many medals, thoroughly enjoys, and this pain has never happened when she is on the ground. But recently, the teachers have advised her to stop sports for a few months till board exams so that she can focus more. Drug history, she has taken antacids and proton pump inhibitors frequently and gets some injection, which they are not aware. After even asking many times, the father is not able to say what injection has been given, but it relieves her totally. On examination, vitals, anthropometry, all normal. There was no weight loss because of this. These episodes happen and they completely settle. In between episode, the girl is fine. Local examination of abdomen, no distension, no organomegaly, no specific tenderness, and no perianal fissures or fistula to suspect an inflammatory bowel. We always think of red flag symptoms and signs. So that was also asked and what was examined as well. There was no such red flag symptoms or signs, both in the abdominal as well as the extra abdominal systems. Now, we concluded that this is a chronic abdominal pain because the history is more than 2 months. By definition, now that recurrent abdominal pain is taken away and it is called as chronic abdominal pain, any pain which persists for more than 2 months duration. So the differential diagnosis was still inflammatory bowel disease we had in the first, because considering her age. She's a 15-year-old girl, and being a girl, again, more prone for inflammatory bowel disease like Crohn's, or it could be a functional abdominal pain. Meckel's diverticulum was thought of, but considering her age, it presents more in the early age group, and the painless rectal bleed is a more common manifestation than just pain. And usually the pattern of the pain is also not like such episodic, frequent episodes. And abdominal epilepsy was also considered. Investigations for the same did not reveal much. Her inflammatory markers were all negative. Urine and motion complete analysis were normal. There was no blood in stools. Ultrasound abdomen had been done in the primary clinics itself twice, reported normal. So we went ahead after a gastroenterologist's opinion with a CT abdomen. Maybe is it a pancreatitis or a diverticulitis or something like that, but that came negative. And an upper GI scopy was also done. So here are the reports. The EEG was normal. The upper GI scopy revealed just patchy erythema, but nothing to suggest a eosinophilic esophagitis, allergic symptoms or H. pylori and so on. And her CT was not showing any significant findings. So now we concluded this is a chronic functional abdominal pain, probably abdominal migraine. So we started her on flunarizine 10 milligram once at night for 6 weeks. She was advised naproxen whenever she gets acute pain. Now, for the past 6 months, she has been symptom-free. She is on regular follow-up. And she also finished her 10th grade, getting 496 out of 500 in her final exams as school topper. And she also got a state rank. But I think more so after finishing 10th also, that stress has gone away and she has not come back with symptoms. So when we come to approach of a functional gut disorder, Rome 4 criteria is what we follow. So we have 3 clusters here. One cluster is clearly the upper GI with nausea and vomiting. The middle cluster is the abdominal pain disorders, which is functional dyspepsia, irritable bowel syndrome, and abdominal migraine. Cluster 3 is the defecation disorders, which is lower down with constipation and non-retentive incontinence. So these are the 3 clusters of functional gut disorders by Rome 4 criteria. Now, to understand it better, this is also called as the gut-brain axis disorder. So we know the microbiota of the gut, the gut movement itself, and the gut-brain axis. All these 3 have crosstalk with each other. So if we have a healthy microbiota, it produces the optimal amount of neurotransmitters like serotonin. And this also keeps the movement of the gut on a regular basis. And there is no hyper or hypo excitation of the gut movement. And finally, the communication between the gut nervous system, that is the enteric nervous system, and the central nervous system is appropriate. But in these conditions, there is a disruption of this whole process. The crosstalk between the microbiota, the gut, and the gut-brain axis is inappropriate to the particular situation. This can be modified by diet, it can be modified by the microbiome, or it can lead to mucosal inflammation, and psychosocial factors can also contribute to hyper or hypoactivation of the gut-brain axis. If there is more secretion of cortisol, there is hyperalgesia and visceral hypersensitivity. So they try to feel that pain. The normal peristaltic pain itself can be hyper-excited in these children because of hyperactivation of the cortisol system. And finally, the vagal nerve, which communicates from the gut to the central nervous system, also gives the input in a hyper-excited way. So the central nervous system itself responds to this whole phenomena, causing more pain to the child. So treatment of abdominal migraine is like migraine treatment. So we follow the stress mnemonic for non-pharmacological management, and preventive management, like in this child, we chose flunarizine, and abortive treatment, we can use analgesics. Moving on to the case scenario 3 is the 18-year-old girl who came with her aunt with complaints of loss of appetite, weight, abdominal pain, lack of concentration and focus, inability to keep up with academics. She is in first year college, in engineering college in Coimbatore. These symptoms were of 5 months duration and occasional dizziness. Again, present illness, there was significant history only in difficulty in sleeping. She also wakes up in the middle with anxious moments, and menstrual history was showed irregular bleeds and with less flow and fewer days. And nothing significant from the past history and the childhood history. Coming to HEDS assessment here, we came to know that she used to be a sporty person at school, but at college now she has stopped. But the significant history after the third or fourth visit without her aunt, she revealed that she was in a relationship which was a very positive kind of relationship, and that broke about 4 months back. And she feels sad about it constantly. She wants to eagerly get back together with that boy, but that's not happening. She still does not understand why this relationship ended. So, unable to overcome these feelings, she has gone into these kind of functional symptoms. So, again, approaching this child, this adolescent girl, she is tired looking and pale. She was alert but anxious and not cheerful. Her vitals were normal. There is 3 kilo weight loss over 3 months, which was significant for us to do at least some basic evaluation before we conclude this is a functional disorder. And the DDs which were kept in mind were all these conditions. Stool and urine analysis was done, which was normal. There was no blood in stools, and blood sugars and inflammatory markers were normal. Ultrasound abdomen reported normal. We did not proceed further with any evaluation. And treating this girl with functional dyspepsia, we started her with proton pump inhibitors, which was given for a period of 6 weeks. So this is a somatic symptom disorder. She very well responded to therapy along with counseling sessions, and she is right now under the management by a team with a psychologist. After that, she came back for a follow-up, and she revealed she is much feeling better now. And she understands her responsibility and her priority is very clear. And she is patient and waiting that this relationship will still come back. So she is still not forgotten that relationship, but she still wants that relationship to be got back. But she is now handling that in a better way. So to conclude, after all these case scenarios, even as pediatricians, we have to say a goodbye to mind-body dualism. We have to approach every adolescent who comes to us in a biopsychosocial approach. We have to plunge into the history. Even though we don't find anything in examination, after a thorough clinical evaluation, getting back to the biopsychosocial approach, getting a good history. It is neither physical nor mental, either physical or mental is not the approach. We have to put everything together and bring a holistic approach when we want to get the diagnosis of a functional disorder. How do we manage them? I will just highlight. Dr. Nivedita will talk more on this. So cognitive behavior therapy is a center for this. There are many expert psychologists who can help us. Stress management techniques have to be taught to the girl or the boy who are going through it. Focus on the function improvement. This is what they want. They want their daily function not to be impaired. They want their school or their academics to happen normally. They want to lead a normal life. So as adolescent pediatricians, we focus on functional improvement, and interdisciplinary approach is needed many a times when we deal with functional disorders. And sometimes we end up using medications as and when necessary. So this is the gist of the cognitive behavior therapy, where the barrier thought, feelings, behavior is broken. They are taught to handle this in a better way, either by body scan mechanism or diffusion exercises, improve their empathetic nature towards themselves rather than an avoidance behavior. Now, when to take the help of a psychiatrist? So when functional symptoms do not improve after any preliminary intervention by us, the symptoms can cause a significant impact on the daily lives of the child, which we are not able to help out. Associated comorbid conditions. We know children with ADHD, autism, or depression can have more chances for a functional disorder. And in functional neurological symptom disorder, to make a diagnosis if it is functional at all, family concerns about the behavior and emotional state of the child. And in a whole, in functional disorders, a multidisciplinary approach is essential. So to conclude, we all know this parable of 9 blind men and an elephant. Many a times we may be searching for a clue from different organs of the child, but most of the times we'll get a clue only by a thorough biopsychosocial history. And functional disorder is not a diagnosis of exclusion. It can coexist with an underlying organic disease too. This is very important for us to understand, but it causes significant distress to the child. So let us understand it is not a disease where they are faking pain. So empathetic approach is necessary. More important, because we have to illustrate to the parents how this happens. For example, why a functional gastrointestinal pain happens. if we show them in a better way, their approach to their child will be much better so that it causes less trouble to the child, and timely refer to specialists and a team management will help in healing. Thank you so much. And I do hope I have done some justice to the topic and will be happy to take questions at the end. And I'm also eager to listen to Dr. Nivedita. Thank you so much.
Thank you, Dr. Jayashree. We will move on to Dr. Nivedita, and we'll have questions at the end of the session.
Yeah. Hi, ma'am. Vijayani, ma'am, and hi, Jayashree.
Hi.
Just joined just after the inauguration. Congratulations to you.
Thank you.
And
thank you.
Jayashree, thank you so much. It was a very exciting session to see. Sorry for joining late, ma'am.
No issues.
Thank you.
Thank you so much.
Hi, Dr. Narmada.
Hi, ma'am. Hi, ma'am. How are you, ma'am? Thanks for joining. Hi. I just missed, had one emergency, went and came back. It became 10 minutes. Sorry, ma'am. Sorry about that. Nice to see you here, ma'am.
Dr. Nivedita, you can start. Ma.
Thank you, ma'am. Good evening, respected dignitaries. So I would like to thank the Adolescent Health Academy of the IAP and the Tamil Nadu chapter of Association of Pediatrics for providing me with this platform to talk about such an important topic. Also, heartfelt thanks to Dr. Jayashree ma'am. She's been instrumental in planning the session. We've had many fruitful discussions over the past 2 weeks. Hope I'm also able to keep up with ma'am. So many wonderful insights that ma'am has provided. So today, the topic is on functional disorders in adolescents. So I would be talking about the in a psychiatrist lens. So how do we view it in as a psychiatrist, especially as a child and adolescent psychiatrist? How do we view the children and adolescents when they present to us? So today I would be briefly talking about the introduction, that is how are somatic symptom disorders seen when they present to us, and would like to talk about a small study which was done in our center to estimate the prevalence of such disorders and understanding somatization, that is what an adolescent undergoes, and the management aspects, and finally a few case scenarios to highlight as ma'am had rightly put it, biopsychosocial approach to manage these cases. So firstly, I would just like to begin with the pediatric psychosomatic medicine. So this subspecialty is dedicated to providing mental health services to children and adolescents with physical illness. So mostly these children present to either pediatric OPD or pediatric inpatient setting where we see them. And over here, these children are found to have associated mental health concerns, and then they are referred for a psychiatric evaluation. So children who are seen in this subspecialty mostly fit into one of the following 3 categories. One is patients with comorbid psychiatric and physical illness. So the child might present with seizures or bronchial asthma, but they may be having comorbid ADHD, anxiety disorder, or depression. The second set of children are those who present with somatoform, that is somatic symptom disorders and functional disorders. And the third set of patients are patients who have psychiatric symptoms that are direct consequence of the primary physical illness. So over here, a very good example would be children who are having autoimmune encephalitis, and they present with a variety of neuropsychiatric symptoms, including psychosis and mood symptoms. So today, my talk would be mostly on the second subset of these children, that is children who are presenting with somatoform and functional disorders. So moving on, ma'am has already given a clear introduction about somatoform, but briefly, just to put it in, so somatization. So somatization is that pattern of seeking medical help for physical symptoms that cannot be fully explained by pathophysiological mechanisms. But of course, now with recent advances, we are also able to understand what causes these symptoms in these children. And it is quite common, almost 2 to 20% of children who present with these aches and pain tend to have the functional symptoms. Also, it's chronic and disabling, but they often do not result in referrals for psychiatric evaluation or treatment when required. Studies have shown this. So even today, there was a patient in the OPD who had presented with multiple somatic symptoms, though she had come for other concerns to us. And when I had told her that initially she has to get evaluated for these symptoms, the concern for the patient was, even if I get evaluated, it would be told that it's all in my head. And she told that sometimes because she has had many negative experiences, so she told that sometimes the doctors, when it's difficult for them to find out, they might tell that there's something wrong with me, with what I think. So why I'm telling this is, many a times such patients face a lot of distress because of the symptoms per se, and also it's even more distressing because of the experiences that they undergo, because these symptoms tend to be unexplained. So what exactly happens, they are also not aware, but the surrounding experience because they undergo during evaluation and treatment is equally distressing. So currently in the DSM-5, the exact terminology is somatic symptom disorder, as Madam had already mentioned. So over here, the criteria is that they should have all these three criteria to be fulfilled. The first is somatic symptoms. So even one symptom is sufficient. So one or more somatic symptoms that are we usually talk about it in two terms. First is, it should cause significant distress to the patient. So, and the second one is, it should cause significant socio-occupational dysfunction for adults. So when it comes to adolescents, we call it as socio-academic dysfunction. So academic functioning of the child may deteriorate, and the social functioning, dealing with their friends, peers, and with their parents, there might be significant disruption in their social life. And the second point is all the three related phenomena, that is thoughts, feelings, and behavior. So there must be some associated abnormality. So they can have excessive persistent thoughts about one's symptoms. This is regarding the thoughts. The second is regarding the emotion. They can experience high levels of anxiety surrounding these symptoms. And the third one is behavior. So they might be spending a lot of time and energy devoted to these symptoms. So they might have frequent doctor visits. They might not be happy once the doctor says that there are no abnormalities. They might go to different doctors, and they might want to get a lot of tests done. So these behavioral symptoms might be noted. And chronicity, at least for a period of 6 months, though it may not just be one symptom. So usually we see migratory symptoms. They might present with one set of symptoms, initially neurological, then they may come up with gastrointestinal symptoms sometimes, and they might be atypical symptoms. The description that they give might be very atypical and vague. So this is the current criteria for diagnosing somatic symptom disorder as per DSM. So usually we face a lot of difficulty with somatoform disorders. As a pediatrician, definitely all of you would have experienced it. Even as psychiatrists, sometimes we face a lot of difficulties, especially with these group of disorders. The main reasons, of course, are first is mind-body dualism, as ma'am had already talked about this. So generally, the mind and the body is considered as separate entities. But sometimes the body doesn't work that way, that the health of a person doesn't work that way. At least we know that in the broader concept of mind, the brain at least constitutes to a smaller extent, the brain constitutes the broader concept of mind. So any abnormalities there, definitely, which are currently not evident in a macroscopic way, but minor abnormalities might be happening there. And the second is about the poor understanding of generally these somatic symptom disorders that we have, and miscommunication to the families. So this is one other this is another thing which we frequently note when I talk to the children. So usually what happens when children have these symptoms and they present to for medical evaluation and everything turns out to be normal, sometimes it is told that the child does not have any difficulty, and that the child is sometimes acting, and the child sometimes is trying to make drama. Sometimes these are the words which the children have actually told. And if you just you can just leave the child will get better on their own. So these are things which are communicated to the families, and these are even told to the school teachers. So even the teachers judge the children, and in front of the other school children, these children get scolded, and they tell that there's nothing wrong with you. It's only you are making up the symptoms. So all this further adds to the distress of the child, and this perpetuates the cycle. So usually there is miscommunication, the poor understanding about the disorder, both to the parents and to the entire social circle of the child. And also sometimes, despite proper psychoeducation to the parents, explaining to them as to how stress can result in all these symptoms, still parents have a very poor understanding. So usually I've seen it is very difficult even sometimes for pediatricians to convince the patients to take a psychiatric consult or a psychological evaluation for the child. They might sometimes tell that there's nothing wrong with my child, and he might not need that consult, mainly because of the stigma associated with these disorders even in this day. So definitely over the past few decades, this has significantly come down, especially post-COVID, but still there is poor understanding of such psychological disorders among parents. And hence, what they would do is they would not stop there. They would start doctor shopping. They might go to other doctors because they feel that they've not got the correct solution. And also lack of liaison sometimes between, as we all know, it requires a multidisciplinary team requiring pediatricians, psychiatrists, psychologists, sometimes social worker. So a proper liaison would definitely help the child better. So just to show this audit on pediatric psychiatry referrals. So this is an audit on patient and clinical profile of outpatient pediatric psychiatry referrals. So over here, children and adolescents, that is children up to 18 years who are referred to the outpatient child and adolescent psychiatry clinic. These children were assessed. So they were mainly referred from pediatrics, but also from other specialties, super specialty departments like pediatric neurology, pediatric cardiology, because these children come from all these different specialties. And once they were assessed, the different diagnoses that these children had, it was made based on ICD-10 and DSM-5, and the data was analyzed for a period of 16 months. So what we had seen was that, so this is the psychiatric diagnosis that most of the children who had presented to the OPD had. Surprisingly, somatoform disorders constituted majority of the referrals and majority of the presentation. So even disorders like anxiety disorders and depressive disorders came later, but most of the children had presented with somatoform disorders. So trying to understand somatization in children. So why do so many children present with somatization, especially in the over the past few years? So trying to understand what exactly goes behind them. So this is a brief model. So it's a developmental model of pediatric somatization. So over here, as we can see, early childhood trauma. So this trauma could be the trauma could be physical abuse. So abuse could be either physical abuse, or it could be sexual abuse, which the children can undergo, or even emotional abuse sometimes, which the children can undergo unknowingly from the parents, and there could be neglect from the parents. So early childhood trauma could result in significant psychological trauma to the child. The child might or might not have experienced physical illness. Following this, when the child experiences physical symptoms, what happens is the child might start paying increased attention to the symptoms that he or she has. And this is what we call as somatosensory amplification. And so there is attribution of these symptoms to physical illness, and this results in somatization. Also, one more point to be noticed is frequent reinforcement by family members. So family members start paying a lot of attention to the child when the child has these symptoms. So this again reinforces the presentation of these symptoms in the child. Also, avoidance of stress can again reinforce somatization. For example, if a child has school refusal, does not want to school, has difficulty in attending the classes, and the child presents with somatization, because the child has these physical symptoms, the child is let free. So he's told that he needn't have to go to school. So this avoidance of stress, so he's got relief from one stress that he's having. So again, this would reinforce the somatization. Also looking at the promoting factors, factors which increases the somatosensory amplification as well as attribution to physical illness of the child. First is genetic. So it is frequently seen that somatic symptoms tend to cluster in families, especially mothers might frequently have some these presentations, as we saw in the case which ma'am had presented. So the mother also had, she also was suffering from depressive episode. And next is the coping style. So generally coping style of child would fall under two categories. The first is emotion focused coping. That is when the child faces any difficulty, the child might start responding in an emotional way, becoming very anxious, angry, sad. And the other form, this is the first form of coping. The second form of coping is that the child might, it's called problem-focused coping, where the child might start analyzing why he has suffered, what has caused the stress, and would try to deal with it. So this is called problem-focused coping. So as it is clear, definitely problem-focused coping is better than emotion-focused coping. But a child who has predominant emotion-focused coping, again, this could be a risk factor for somatosensory amplification. And the family model, a family in which there is a lot of marital discord, the parents are fighting. So here, when the child falls ill, the attention falls from the discord to the child. So this kind of gives some sort of relief to the child. So the family model is also important. Socio-cultural background, children who face a lot of poverty and poor economic status and whose parents are illiterates, they are more prone to develop these symptoms. So this is a developmental model of pediatric somatization. So elaborating further on this, so of course we had seen about the role of stress at the beginning. So how does stress contribute? So we've already seen about the HPA axis in the earlier presentation, but I would speak more relating to how emotions actually affect this. So as we know, when there's a perceived stress, the hypothalamus with CRH secretion would result in pituitary secreting ACTH, which would further stimulate adrenal secreting cortisol. But what else also happens here? Hypothalamus has a bidirectional link with the brain centers that process emotions. So what happens is the HPA axis. So it is through this particular HPA axis that emotions exert their effects on organ system. So emotions such as anger, anxiety, sadness, all these can have an effect on the organ system, and this happens through the HPA axis. So generally, when the child might be suffering from an acute stress and chronic stress. So as we know, acute stress would be brief, and then it would resolve in a brief period. But chronic stress is something which is present for a long duration. So this chronic stress can happen when the child either is suffering from a difficulty from which he cannot escape. For example, the child is being continuously abused by a known person at home, and the child cannot escape. So this is from a situation where the child is not able to escape. And the second one is the child is facing stress, but the child themselves are not aware of it. For example, it could be an emotional abuse. The child is not aware that he is being emotionally abused, but the child is continuously facing it. So these are examples of chronic stress. So stress, so when chronically stressed out child, so stress response triggered chronically results in harm to tissues. And over here, the salient stressors that we are concerned about are emotional stressors, because in the modern society, the emotional stressors are predominant. So also when looking at the emotional response in the child on a deeper level, it's seen that first the child has a subjective experience. That is, the child knows that I'm having this emotion. That is either I'm happy, I'm sad, or I'm anxious. And at the second level, the child might not be aware of the emotion that the child is undergoing. And but this might be the emotion that the child is undergoing might be evident through their facial expressions, through the gestures that they make. For example, if a child is very anxious, the child sometimes may not be aware consciously, but the child might start blinking, the child might start talking really fast, the child might start fidgeting and restless. So all these are emotional displays, probably without awareness. And the third level is physiological changes which are triggered by the stimuli. This might not be apparent to the child and sometimes even to the person who is watching the child. So here, in accordance to the flight and fight response, the child starts facing many different changes in the body. So why is this important? This is because when the child is inhibited from acting out of these emotions, for example, a very young male boy, the male child is told that you must not cry. So the child is inhibited from acting out his emotions. The child is very sad, and as a result, the child subconsciously starts crying, but is immediately stopped by the parent telling that it is not good to cry. So what happens? The child is conditioned to respond in future by repression. That is, even in future, when the child faces a similar situation, the child feels that he's not supposed to cry because he has already learned this. So he represses his feelings. And because of this, finally, the emotional competence of the child is compromised, but it doesn't stop there. This results, the emotional competence is compromised, but as a result, this child starts taking, takes the role, form of physical symptoms. So also seeing how the child can deal with this over here. So this is what we call as emotional competence. That is the ability of the child to deal with the emotions in an appropriate way. So the ability of the child to understand what emotions they are undergoing and how to deal with it. So firstly, the child must be taught, or the child must realize, have an awareness about the emotions that they are undergoing. It could be positive emotions like happiness, surprise, or negative emotions like sadness, anxiety, anger. And the child should be the child should be able to express the emotions in a proper way. This is very important for the child to establish a emotional healthy boundary. Sometimes when the children don't do this, they also grow up to adults where they're not able to establish this healthy emotional boundaries. This is because they want to please what others say, but at the cost of their own well-being. And also, the child must be able to understand the whatever emotion that the child is undergoing, whether it is a psychological reaction for the present or it is a residue from the past. That is some other trauma or a stressor which the child has experienced in the past and is still continuing to feel the effect of it currently. And finally, acknowledge that the emotion that the child has, rather than repressing these emotions, suppressing the emotions for the sake of others. Instead of this, the child has to acknowledge the emotions. This is very important to foster emotional competence in children, because when this is affected, results in the child developing all these. It is a risk factor for the child developing the physical symptoms. So moving on to the management aspect. So again, going on to our same, the model of pediatric somatization, we'll just look how we can counter it at these individual levels. So first, when the child faces early childhood trauma or psychological trauma, psychotherapy can be beneficial. So in psychotherapy, we speak more in terms of cognitive behavior therapy. So in cognitive behavior therapy, as we know, it's a triangle of thought, emotion, and behavior. So it is the basic concept behind CBT is that once our behavior is capable of influencing our thoughts and emotion. Similarly, emotion is capable of influencing our behavior and our thinking. And similarly, thoughts can influence the behavior and emotion. That is, it is a triad, and each one is capable of influencing each other. So in CBT, what we do is we try to target the emotions in many cases. So we try to change the behavior of the person. Similarly, we also try to change the thinking of the person. By targeting both these, we try to achieve a change in their emotion. This emotion could be a negative emotion resulting in a depressive disorder with sadness, or anxiety disorder with a lot of anxiety. So this is how CBT works. And in individual psychotherapy, CBT models are employed. And also sometimes when the psychological trauma is severe enough to cause disorders like depression, anxiety, medications might be needed. So so there is a role of psychopharmacology over there. And coming on to physical symptoms, which happens due to somatosensory amplification, for this, what we call hypnosis, biofeedback hypnosis can be helpful. That is basically, we are trying to teach the child to engage in a lot of relaxation activity. So 2 relaxation activities can be commonly taught to children. The first one is imagery. So in imagery, what happens? The child is told or is taught to imagine certain pleasant situations that the child has, or certain pleasant situations which the child would like to experience. And when the child does this for a few minutes, it automatically relaxes one's body. So this is about visual imagery. And the other form of relaxation technique is called progressive muscular relaxation. So over here, the child is taught about various techniques to progressively relax oneself. So relax the various muscle groups of one's body. And once the child does it for the entire body, he feels completely relaxed. So these are certain relaxation techniques which can be helpful to combat somatosensory amplification. And finally, attribution of symptoms to physical illness. Definitely, these symptoms could result in in other physical illness. So one is psychoeducation about the particular disorder, how stress can also result in these symptoms. So that is important. We'll be seeing more about psychoeducation in the following slides. And finally, when there is significant reinforcement by family members, family therapy can be beneficial, where we advise the family members to cut down the increased attention given to the child, the gains that the child is having. Also, if there is significant familial stresses like marital discord, there is a scope to address all this. So over here, the role of a psychiatric social worker or medical social worker can play an important role over here. And finally, behavior modification. So over here, the child is taught the positive behaviors of the child are reinforced when the child engages in other activities or starts going back to school. And negative behaviors such as avoiding school is not reinforced over here. So this is a model as to how the various aspects of pediatric somatization can be addressed. So moving on to another very important aspect is that mostly somatoform disorders or somatic symptom disorders are frequently comorbid with other psychiatric conditions. So this is seen in almost 40 to 60% of the cases. So most commonly noted conditions are mood disorders, including depression and anxiety. Sometimes children with neurodevelopmental disorders like ADHD can present with these symptoms. So what is thought is that generally when there is no outlet for the children to express their stress, then the children express their stress through a more culturally appropriate way, that is pain or other physical symptoms. So that is thought, it is thought to underline the presentation of these symptoms. So in case of underlying, so it is very essential to always look for comorbid psychiatric conditions when these children present, and pharmacotherapy may be needed in moderate to severe cases. So usually when the child presents only with mild comorbid disorders, then psychotherapy is the first line of choice for depression and anxiety. But when the child is having severe symptoms, significantly distressing symptoms, then medications might be required. So just a brief word on the medications which are commonly used for children. So though there are multiple antidepressants, SSRI medications for adults, there are only few medications which are approved for children. So the first line is always fluoxetine. Multiple trials have proved that fluoxetine is especially safe for children above 8 years. So it started at a dose of 10 milligrams and up titrated. And second line drug is sertraline, which is usually started at 25 or even lesser dose 12.5, and it is up titrated. And as third line, escitalopram can be used, which is FDA approved for children above 12 years. One major consideration with SSRIs while starting it for adolescents is what we say emergence of suicidal ideations during the first few weeks of initiation of treatment. So during the first few weeks of initiation of treatment, there could be some increase in anxiety, and the child is more prone to develop suicidal ideations. So you must always watch out for this. And during this time, addition of anxiolytics can help the child. But over a long period, once the child's underlying symptoms starts getting treated, then during that time, these symptoms will resolve. But it is always important to look for emergence of suicidal ideations once SSRIs are initiated for the children. And other than medications, moving on to psychoeducation, which forms a mainstay of treatment for somatic symptom disorders. So first is reassurance that the child is not having any major life-threatening condition is very important, both to the patient and to the parent. And also the link between stress and physical symptoms have to be taught to the parents. So one approach which we usually take in the OPDs, we give them this metaphor. So suppose the child happens to view a snake and the child gets very anxious, then during that time, the child would start experiencing physical symptoms like palpitations, tremors, sometimes breathing difficulty, sweating. So there is the link between this emotion that the child is facing, that is anxiety, and physical symptom. So this is universal because everybody would face these physical symptoms in such anxiety provoking situation. So this is again extrapolated, and it is explained that, so similarly other stress producing situations can result in physical symptoms. So when this metaphor is given, it is easier for the parents to understand. And also the crucial role which the family plays, especially for reinforcing as well as to reduce gains for the child. And the rehabilitation model, which focuses on returning to normal function. So despite having all the symptoms, it is essential for the child to have a normal routine and if possible to get back to school and start functioning. So once the child gets back to the routine, that itself could serve as a form of treatment for the child. And it is very important to have a ongoing liaison between the treating psychiatrist and the pediatrician. This is because though the child has been diagnosed with a particular condition, somatoform or somatic symptom disorder, sometimes it carries a very negative label for the child. So whenever the child goes and visits any doctor for any other condition, the child is frequently thought of having somatic symptom disorder, and this can carry a negative, this has a very negative label, this can have a negative label for the child. So hence, it is important that whenever child develops any new symptom, it has to be evaluated with the same way as any other child who's presenting with it for the first time would be evaluated. So very important to have an ongoing liaison between the team. And this is the cognitive behavioral therapy framework for somatic problems. So briefly over here, so as the child experiences body symptoms and sensations, and the child is parents are taking the child for multiple consultations, and she's avoiding normal activities, so there could be misinterpretation of symptoms. So as we had already discussed in cognitive behavior therapy, one aspect is changing the behavior, which could have an impact on the emotion. The other aspect is changing the thought pattern, that is thinking, cognition. So here the children can have what we call as cognitive error. That is, the child is having a thought which the child thinks is true, but which may actually not be true. So that is called as cognitive error. So two types of cognitive errors are noted in somatic symptom disorder. One is called catastrophization. So here the child might be having a minor symptom, but the child starts interpreting those symptoms to be something very big, something life-threatening. And so this is called as catastrophization. For example, if the child has headache, the child might be having headache at the end of a really long, tired day. The child might feel exhausted, might be dehydrated. But if the child starts experiencing minor symptoms, immediately he might think that he's having, it could be something related to malignancy. So this is called catastrophization. This type of cognitive error is frequently noted in somatoform disorders. Similarly, the other cognitive error which is noted in such adolescents is all or none thinking. So here the child may feel that if he has these symptoms, the child has to go to the hospital and get everything done. If not, the child is going. If this is not done, then the child, something life-threatening could happen to them. So this is the all or none phenomenon. So misinterpretation of symptoms frequently happens, and this has to be addressed. So finally, moving on, I would just like to present two cases and highlight the few points that we had noted in these cases. So first, case one is the child was referred from pediatrics because mostly children first present to pediatrics, and from there they get referred. And the reason for referral was they were persisting GI symptoms, pain, abdomen, loose stools, extensive organicity workup was normal. So he was a 13-year-old male child studying in class 7 and from Pondicherry. So there was no significant past or family history. So the presenting complaints were he had gastrointestinal symptoms for 2 years, predominantly pain, abdomen, and episodes of loose stools. And because of this, he was irregular to school for over 2 years, and he was absent for the last 3 months. So he was evaluated in 2 different private hospitals and then referred to a tertiary setup. And again, the investigations were all normal. So following this, he was referred to the Child and Adolescent Psychiatry Unit for further evaluation. So upon seeing the child, mental status examination, that is assessing the mental status of the child, it was noted that he was a well-kept child with anxious affect. He told that I'm not able to attend school because of my symptoms. If I go to school, my symptoms worsen. But he, however, told that I like to go to school. He told that if there are no classes and if he's allowed to be only with his friends and play the entire day, he would definitely like to go to school. So keeping that in mind, when we probed further, it was found that he has difficulty in his studies. And this is mainly because he's having difficulty in concentration. He's not able to sustain his attention for a long time. And following this, after taking detailed history and structured evaluation with scales, it was found that the child has attention deficit hyperactivity disorder, which was affecting his academic performance. So usually in child psychiatry, when we make a diagnosis, the diagnosis is made in 5 axes because, as ma'am had told, biopsychosocial approach has to be taken. So this we do it in the diagnosis itself, taking the different factors into account. So in the axis 1 consists of the primary psychiatric disorder that the child has. Axis 2 consists of any other developmental disorders that the child could have, like a learning disability. Axis 3 generally speaks about the intellectual functioning of the child. Axis 4 about any other comorbid medical illness that the child can have. And axis 5 speaks about others associated psychosocial issues present in the child. So for this child, he was diagnosed to have ADHD, and somatoform, which actually ADHD, which was masquerading as somatoform disorder. Otherwise, an intelligent, well-performing child, and he had presented with school refusal to us. So treatment-wise, medications were initiated. Initially, propranolol, a good anxiolytic medicine, especially to help with the autonomic arousal. So this was initiated, and this helped him return to school. And also anti-ADHD medication, he responded to atomoxetine, which was uptitrated up to a dose of 25 milligrams. And following this, his ADHD symptoms had reduced. And again, psychosocial interventions play a major role. Over here, the parents and the child were psychoeducated about the mind and body link, and then the child did not just present with the GI symptoms like that. He had some underlying stress, and then the stress was that he was having difficulty in studies. When this was told to the parents had dismissed it. They actually thought that the child is lazy, he does not want to study. And because of this, finally, the symptoms presented in a way which suggests somatoform disorder. And also, the other component is parent training for ADHD. Generally, parents play a major and crucial role in treating children with ADHD. Many activities and structuring the child's day by the parents itself can have a huge impact on the child's symptoms. So one is ensuring that the child has adequate energy draining activities throughout the day. For ADHD helps the child. Similarly, attention enhancing activities which can be given by the parents themselves at home, and engaging the child in household activities. So all these are components which are taught to parents during the parent training. So he was given both pharmacotherapy and psychosocial interventions, which consist of both these. So finally, on following up the child, so there was significant improvement in his GI symptoms in 2 months, and his ADHD symptoms improved, and finally his academic performance also improved. So this clearly showed that the child is good in studies, but because of this particular condition, he was not able to perform well. And he started becoming regular to school after 2 years of poor attendance. So this is how ADHD presented in a child, but the child presented as somatoform disorder first to us. So the key take-home points from this case for us were, so somatoform disorders, again, they are most common presentation to what we call as consultation liaison in child and adolescent psychiatry. This is because frequently these are the cases which mostly get referred from various departments, and they are frequently comorbid, must always look out for other associated psychiatric conditions. And psychoeducation plays a key role, because sometimes it is difficult for parents to understand how stress can result in these symptoms. And even if we explain, sometimes they might not continue the treatment. They might want to again evaluate and reevaluate the child in various settings. So this is about the first case. Moving on to the second case. So here again, the child was referred from pediatrics department, and the reason for referral was episodic presentation of cough and sore throat for 6 months, and the organicity workup was normal. So she was a 14-year-old child studying in class 9 from Coimbatore. So with no significant past and family history. The presenting complaints were that she had cough and sore throat for 6 months, but it was of episodic presentation. So whenever she had these symptoms, it was only for a period of 1 to 2 days. And over the past 6 months, however, she has had it 4 times. And each time the child develops these symptoms, she insists on hospitalization. She definitely wants to visit the hospitalization. And she usually gets admitted in the hospital. And after getting admitted in the hospital, within 1 day, the symptoms would usually resolve and she would get back home. So a recurrent pattern was noted because almost it had happened close to 4 times in 6 months, and detailed evaluation showed that there were no other abnormalities which could be detected through investigations. So she was referred further for the psychiatric evaluation. So the mental status examination of the child revealed that she was a well-kept child with anxious affect. So first when she was when she had consulted during that episode, the child did not speak. She was just able to utter that I have severe pain, I cannot speak. So the details were taken from her mother. But however, after 2 days, she was again called back to the OPD. The child was doing well. She was completely fine. She had resumed her premorbid self, and she was able to talk as usual. And when asked regarding her stressors, the child reported that there were no major stressors. And usually during these inter-episodic period, she maintains well. But this pattern kept on repeating. And usually it was her mother. She showed significant interest in treating her, and the mother used to bring her. So it was told that the child would benefit from cognitive behavior therapy and she would need to undergo regular sessions. So the mother used to bring the child for regular sessions, and she was very much involved with the treatment. After a few months, the mother had reported alone. She told that this time the consult was not for the child, but for her. And while discussing it in detail with the mother, it was noted that the mother herself has undergone significant stressful events in life. So her brother had passed away when she was very young, at around 20 years. And around 4 to 5 years back during COVID, her father had also passed away. So post that, she was becoming very anxious. And so what was later found was every day she used to use a pulse oximeter, and she would use the recordings not just for herself, for both her children, her elder son and for her daughter who's the patient, and as well as to her husband. So every day she would know this, and if she notices any mild changes in the usual recordings, then she would start panicking. But every day she would make even the family members undergo all this. So it was later after taking a detailed evaluation of the mother, it was found that she herself has anxiety disorder, and that the mother's anxiety was having a significant impact on the child's health. So for the child, Axis 1 diagnosis of somatoform disorder was made. She had average intellectual functioning and Axis 5 psychosocial stressors, familial stressors relating to mother's anxiety disorder. So treatment for the child, initially pharmacotherapy, because the symptoms were very brief lasting. Medicines were given only for that 1 day or 2 days on an SOS basis. So if required, if the child has a significant anxiety, anxiolytic clonazepam was suggested. However, for psychosocial intervention, the parent and the child were psychoeducated regarding the symptoms. And also then the mother was started on treatment. The mother was started on SSRI medications and CBT for anxiety also. So there was significant impact of mother's anxiety on the child. So following this, mother has started showing improvement in her anxiety symptoms over the next few months. And during this period, the child was also maintaining well. She did not have any further episodes of such episodes which she was experiencing before for the next 3 months. So mother also started reporting improvement in anxiety, also her coping skills. So despite having stresses in the last 3 months relating to family members, she was able to cope better. And child symptoms seemed to resolve once the mother's anxiety was treated. So again, the take-home points from this case were the importance of biopsychosocial approach for the child. So here the social aspects played a crucial role. That is the atmosphere that the child was having at home, and also the anxiety which the mother had, and coping patterns of the child. So here the child immediately wanted hospitalization, even if the child even slightly experiences the symptoms. So all these 3 aspects had to be addressed. And reinforcement by family members played a crucial role. Though the child was not able to report, initially she told that the child does not have any stressors, and first report, the family history of psychiatric illness was also not reported, but reinforcement by family members is very crucial. So definitely mother's anxiety played a significant role in the child's symptoms, though the child was not able to verbalize it. And the family model, that is the difficulties which the family undergoes, will definitely have an impact on the child's mental well-being. So finally, to conclude, the somatization is highly prevalent among children, so which we frequently see around 2 to 20% as the cases as per studies, but we see an increased prevalence in the last few years. And it is frequently comorbid with psychiatric condition. So definitely any child who presents with somatoform disorder has to be looked for comorbid psychiatric issues. And taking a biopsychosocial approach will give a holistic management to the child. And definitely a multidisciplinary team, as I had already mentioned, with the pediatrician, psychiatrist, psychologist, social worker, everybody is needed to address the distress of such children. So these are the references. And before concluding, again, I would like to conclude with this particular paragraph from this book. So this book is called When the Body Says No. So that is the hidden cost of hidden stress. So sometimes we're not able to express the stress that we have, but when we do not verbalize it, sometimes the body would start expressing, and the body would start saying no. So this particular line, this particular paragraph, which Dr. Gabermate says, that is dualism, cleaving into two, that which is one, colors all our beliefs on health and illness. We attempt to understand the body in isolation from the mind. We want to describe human beings as though they function in isolation from the circumstances in which they live, work, develop, play, and die. These are built-in hidden biases of the medical orthodoxy that most physicians are made to absorb during their training and carry into practice. So aptly it would apply to somatic symptom disorders. So with that, I would like to conclude. Thank you.
Thank you, Dr. Nivedita. Very beautifully presented, extensive, and gave a lot of clarity.
Thank you,
And
ma'am.
thank you to both of you, given almost everything about the functional disorder. Any doubts from the audience can be clarified now.
There were some questions in the chat box.
Yes. One Dr. Revati is asked value of non-pharmacological management in mild to moderate like yoga and music therapy. Is there a role for that? Do we advocate that?
Yes, ma'am. So
Yeah.
can I go ahead, ma'am?
Yes,
Yes,
yes, yes.
please, please.
So generally, when the children present to us, we always talk about other lifestyle modifications which has to be made by all the children. So definitely this includes regular exercise and ensuring they have good sleep hygiene. Along with that, definitely yoga and meditation can play a major beneficial role. But for meditation to have a good role, the child should engage in meditation on a regular basis. So at least for a minimum period of 3 months. Only after that they would start noticing some difference. So what is noted, what even studies have shown that regular engagement in practices like meditation can have structural changes in the brain itself, can bring about long-term impact and reduction of symptoms of anxiety, ADHD symptoms. So it can definitely be beneficial, but not as a standalone treatment. Always better to suggest it along with the other forms of treatment.
Thank you,
Can I
Doctor.
add something, ma'am?
Yes.
So Dr. Porpave in her class of pediatric psychiatry always used to say, don't work on the negative aspect of the child. Look at the protective factors. So as we saw the predisposing, precipitating, perpetuating factors of any psychological illness, there are always protective factors in the child which we have to look at. And of this, Dr. Revati has suggested this music, whatever extracurricular activities the child had been doing. If that is stopped, that can also serve as a perpetuating factor. So this music, yoga, and exercises, sports, everything comes under that protective factors, ma'am. It definitely increases the endorphins, and it also brings up a positive way to life.
Thank you, Dr. Jayashree. I have a question. Like we had been talking about gut microbiome and the gut access to the brain. You have anything? We don't integrate that in a modality of treatment. Anything new about it, ma'am? No.
Yes, ma'am. Lot of studies have been done where in functional gastrointestinal disorders, especially. Not only that, even in neurodevelopmental disorders like autism, ADHD, in all those fields also now there are studies going on. Not any like proven studies are not there, ma'am, to make it as a prescription for a particular disorder. But off-label, it has been used to promote the good gut microbiome if we find definitely an evidence. For example, in a child with Crohn's disease, they do analysis of the stool to look at the gut microbiota. It is now routinely done by gastroenterologists. So if they find that the gut microbiota is unhealthy, even in a organic disorder like Crohn's disease, inflammatory bowel disease, now they are trying to give that as a supplementary treatment apart from the routine medications given. So it definitely has a role in functional gastrointestinal disorders.
Thank you, Doctor.
Dr. Nivedita, you want to add anything in psychiatry where you come across the usage of probiotics?
Yes, ma'am. Currently as for neurodevelopmental disorders, but of course it can, as you've told, it can have a major role in this also, ma'am.
Yes, sir, you wanted to say something. Dr. Jalil, sir, please.
It's Dr. Jayashree in the functional disorders, that is precordial catch syndrome. Routinely we come across in young girls. I mean, adolescent girls, no? How would you assess it? And then it's a very common presentation, precordial catch syndrome.
Yes, sir. So one of the clustering of symptoms in a young girl or a boy in the adolescent age group due to various emotional stress is the precordial discomfort, having palpitations or excessive sweating associated with it, sometimes even to the extent of syncope. So it is definitely there, sir. Very commonly we see in those conditions, we cannot avoid investigations as well because this evolves around a major organ. We definitely do basic evaluation like looking at an ECG or having basic blood workup to look at anemia, to look at vitamin deficiencies and so on. And once we try to make out that none of the red flag symptoms and signs are there, then we can definitely reassure them because parents also, when it comes to the chest pain sort of complaint, they definitely want some investigation to make sure that the child is completely fine. So in that conditions, we do evaluate a bad minimum basic evaluation and then counsel the child.
I think next to headache, this symptoms is very common.
Gastrointestinal symptoms are also very common to our clinics.
Thank you.
Dr. Chandal, so a CB member, an active person of AHA, please say a few words about our meeting today. Thank you.
Thank you so much for the opportunity. I must say that today's CME was excellent, and the one take-home message will be that we have to see that the mind and body should not be disconnected. We have to take both together, and so that is what we have to take it up. And of course, both the speakers, Dr. Jayashree and Dr. Nivedita, I must appreciate their wonderful homework, spade work, smart work, and all the work they have put in for this wonderful presentation. I really appreciate them sincerely. And we have to definitely see that நம்ம தமிழ்ல சொல்லுவாங்க உடம்பு சோர்ந்தா மனசு சோறும் மனசு சோர்ந்தா உடம்பு சோறும். So this mind and body has to be definitely dealt with, and this will be the definitely you have driven home the point. And I really sincerely acknowledge Dr. Vijayarani's contribution, coordination, and Dr. Lakshmi Shanti's wonderful comparing. And really, thanks all the AHA dignitaries who have come over and presented here. And thanks for the opportunity. It was a fantastic learning experience.
சார் உங்க பாணியில சொல்லணும்னா நோய் நாடி நோய் முதல் நாடி அது தனிப்பர் வாய் நாடி வாய்ப்பச்செயல். So I was thinking of this திருக்குறள்.
Superb. You finished it off in style. And also I appreciate our doyen of adolescent medicine in Tamil Nadu, Dr. Yamuna's presence. Thank you,
Yes,
Yamuna,
sir.
for coming.
So happy that Dr. Yamuna joined today.
Dr. Yamuna is here.
Yes, ma'am. She is here, ma'am.
No, it's really, we love to see her. Yamuna, greetings from AHA, and especially myself was trying to contact you personally. I hope you're okay.
Is she there?
Probably she has left.
Yeah.
She's there.
Yeah, that's great because Yamuna, nice to see you, yeah. Because I have also learned a lot from her. She's one of my teachers.
She was first one.
You're muted, Yamuna.
Yeah.
You're muted. Yeah.
See her. Hi, all of you. I am a silent spectator of what's going on around, and I am really appreciative of all of you doing a grand work and involving younger generation psychiatrists, younger generation specialists to come on board and to share their views, mainly because the youngsters have to take over, and it is essential that more and more people speak about adolescents and look after adolescents, because they are not having enough medical professionals to take care of them. So I want more and more doctors to get initiated in this journey and take the flag forward. May God bless you all. Wish you all the best. And you're doing great work. Hats off to the Tamil Nadu team. I don't know who is heading. I'm just keeping myself away from all IAP activities. So I don't know who is who, but my appreciation and congratulations to all of you.
Your friend
Thank
is
you.
heading.
It
Your
was so
friend is
nice
heading.
to see you,
Thank
Yamuna.
you,
Vijayarani is
Dr.
heading.
Yamuna. Thank you so much.
Yeah, take care.
Thank you.
Thank you, ma'am.
All
Thank
of you, they are doing great work. Nivedita, hats off to you.
Yeah.
After a long time, I'm listening to a new psychiatrist talk about somatoform disorder, because for a period we were only listening the same specialist talking. So now we have new ideas, new approach, and your commitment to child and adolescent psychiatry. Please let it continue, because children need you.
Thank
Okay,
you, sir.
may God bless you.
Thank you, ma'am.
Yeah.
And also
Thank you,
thanks to Dr. Shamik sir for proposing this topic and Jayashree to carrying it forward.
Thank you
Can
so
I
much, sir.
just have a small input over here? Firstly,
Yes,
it's
sir.
been a great education, listening to both the speakers today. And I'm so glad that the whole biopsychosocial model has been emphasized as the basis of our approach, because with very common terms, we have to be very careful that the biological rhythm in our children is not disturbed. Most of the problems, whatever problems we are facing, whether we talk about anxiety, whether we talk about somatoform disorders, there is usually a disturbance in the equilibrium. Your sleep is less, your activity is less, so you're metabolically slow. So all that we talk about in early childhood development as prevention, we have to make sure that that is carried on through mid-childhood and into adolescence. Because the moment the biological rhythm of a person is disturbed, the moment the environment is disturbed, the social structure is disturbed, and what we find, whether it's at home or whether it's at school, all these issues will start precipitating. So if we have a good understanding when we are doing our regular pediatrics about advising children to have a certain amount of normal physical activity, like doing their own beds, setting up their own study tables, ironing their own uniforms, there are small things which will contribute to re-establishing the biological rhythm. That is what I think. So as pediatricians, we can do as groundwork or spade work so that children don't get disturbed. Thank you so much. It was a
you, sir.
wonderful, wonderful session.
Thank you very much, sir.
I would just like to add on and request Tamil Nadu, you all are so committed that why don't we work around mental health, get some data out of the work what we are doing, because we have so much of expertise within AHA and now IAP also. So we are actually focusing a lot on mental health. So the adolescents should know whether they themselves can screen whether they are mentally well or not. So something like empowering them. So we are through this program of Empower You also, we are trying to tell them that they can assess for themselves. So likewise, we can have some insights into what are the, what does the youth, what are the issues with the youth regarding mental health, or some profile or data can come out from community, schools, colleges, adolescents in Tamil Nadu. You can also think of taking out, some data. You require data from, we're lacking in data in India. Can we
Actually, we are working on it with Dr. Sridevi professor from ICH and IAP AHA together. So we are just forming the team and preparing the questionnaire. And our target to start from the month of June. So if we start now, when the school reopens, we'll be doing that. We are at it.
Thank you. Thank
Thank
you,
you.
Vijayarani.
Thank you, sir.
Great. Congratulations to the whole team of IAP and
Thank
AHA
you.
Tamil Nadu. Great.
Thank you.
Thank you.
Thank you so much for joining.
Thank you very much. And
Thank you,
we are
sir.
looking forward
Thank
to
you.
more opportunity.
Vijayarani.
Thank you. Thank you so much. Since there are no more questions, we shall conclude today. And we are very, very elated about the distinguished presence of all people from Central and the state IAP and AHA. Thank you very much. And the wonderful speakers added more stars to it. Thank you all. Thank you.
Thank you, ma'am. Good night. Thank
Good
you.
night. Good night.